Hi, everyone. Welcome to Osteobites. Thanks for joining us. Let's give a couple seconds for everyone to get settled and join us in our virtual room. My name is Christina Iktoma, and I am mom to Osteo Angel Dillon and the Director of Scientific Programs for MIB Agents. And today on Osteobites, we are talking with Dr. Katie Janeway and Ben Zola about the Count Me In project and the importance of patient-powered research. Thanks so much, Dr. Janeway and Ben, for joining us on Osteobites today. We are thrilled to have you. And since we're talking about patient-powered research, we couldn't have an Osteobites on this topic without some patients and caregivers. So thank you so much to the awesome crew joining us today. We have Colette Ramber, who is mom to Osteo Warrior Allison. And we also have Osteo Warriors Max and Jillian. And Allie, Max, and Jillian are also on our MIB Agents Junior Advisory Board. I also just needed to point out that today marks our 101st episode of Osteobites, which is amazing. Of course, I didn't notice last week when we hit 100, but 101's better than 100, right? So we appreciate that we have a little bit of a group and a kind of a party here on Osteobites to celebrate that occasion. So a little bit more about our guest today. Dr. Katie Janeway is a pediatric hematologist-oncologist at Dana-Farber Boston Children's Cancer and Blood Disorders Center with clinical and research expertise in precision cancer medicine and solid tumors, particularly sarcomas. The focus of her research is the genomics of pediatric solid tumors, including expanding the benefits of the precision cancer medicine approach to children with these cancers and poor prognosis. And in addition, she performs clinical trials of new therapies for pediatric sarcomas. Her prior work has defined the genomic underpinnings of osteosarcoma and GIST and determined that non-standard personalized medicine tests are commonly marketed to cancer patients as being beneficial, and established that a multi-institutional precision medicine study is feasible and demonstrated that a significant proportion of children with difficult-to-treat childhood solid tumors have genomic results with potential clinical benefit. She's the lead pediatric investigator for a comprehensive somatic genotyping study, which has enrolled and sequenced tumors from over 400 pediatric patients. And for clinical trials in sarcoma, she is the chair of the Bone Tumor Committee of the Children's Oncology Group, the principal North American Pediatric Oncology Clinical Trials Consortium. And then we also have Ben Zola from the Bright Institute joining us today. He's a project manager with Count Me In, which is a nonprofit research initiative that enables patients to accelerate cancer research by sharing their samples, their clinical information, and their voices. Ben has been with the team for over 2 years, and he specifically manages Count Me In's projects in osteosarcoma and also leiomyosarcoma, and he has a bachelor's degree from Rutgers University in biomedical engineering with a minor in psychology. So welcome, Dr. Janeway and Ben, and welcome to everyone joining us today. Please feel free to add any questions that you have or comments to the Q&A as we go. And then before I hand it over to our panelists to introduce themselves, I do have some announcements and reminders. Our third annual Outbidding Osteosarcoma auction is now live, and there are some fantastic and unique items and experiences. The categories include luxury hotels and travel, original art, home goods and beauty, other really unique experiences. I will say, if you haven't planned your summer vacation yet, there are some amazing hotels on there, and there are even plane tickets, so you can plan your whole summer vacay on the Outbidding auction site. There's also original art by Osteo Warriors if you want to add some color and spirit to your office. And then there's some really unique items like a Daytona racetrack experience. You can have Chef Nathan from Twin Farms, which I think was recently voted best hotel restaurant in the country. A private dinner catered by Chef Nathan, an illustrated portrait of your family by the amazing artist Anna Eggleton. So if you haven't gotten around to your Father's Day gift, there's some really good items there. So check it out. I'm going to put the auction link in the chat, and we encourage you to share the auction link with your friends and family. Maybe drop a hint to a family member about something that you would really appreciate for Father's Day or some other upcoming occasion. And then there is still time to register for Factor, which is in 2 weeks. I will also put more info in the chat about Factor. The Count Me In team is going to be there. Ben's going to be there. Also, Dr. Diane Deal, who is the director of Count Me In. She's going to be presenting on our biomarkers panel. She's also leading a discussion group with Dr. Nino Reynuso from Texas Children's Hospital about patient-powered research. So if you are interested in enjoying the discussion today, there's going to be 2 hours of live discussion on this at Factor. So I hope you can join us. So let's go to our panelists. Colette, could you go ahead and introduce yourself?
Hi, I'm Colette Rambert. I'm mom to Osteo Warrior Allison. We live in Houston, Texas, and we received treatment at Texas Children's and a little bit at MD Anderson too. I became part of MIB agents, I guess it was halfway through your treatment when we found out it was osteo, and they've just been wonderful to our family, and we've loved every bit of it. Ellie?
My name's Ali, and I was diagnosed with cancer in November of 2019, and I have been cancer-free for almost 3 years now, and we recently attended Factor last year, and as of this year, I've been a part of the MIB Junior Advisory Board.
Great. Let's go over to Max.
Hi, Max. I'm from Long Island, New York, and I'm a high school senior. I was diagnosed with osteosarcoma in my right distal femur when I was 10 years old in 2015, and I've been 7 years NED since. And with MIB, I'm on the Junior Advisory Board. I'm an ambassador agent, and I've been at Factor and outsmarting events before.
Thank you, Max. And hi, Jillian. Could you introduce yourself?
Hi, I'm also on the Junior Advisory Board. I'm 17 years old, and I'm currently a high school junior. I was diagnosed with osteosarcoma back in 2017, December, and I'm currently about nearly 5 years cancer-free, which is really great.
Yeah. So glad you guys could join this patient-powered discussion. So we're going to hand it over now to Dr. Janeway and Ben, who are going to give us a little bit of an overview on Count Me In. But this is really meant to be an interactive conversation. So they'll give us a kind of a bit of an overview, and then we will open it up for questions. So thanks. I'll let you take it away, Dr. Janeway.
Wonderful. Well, thank you so much for the lovely introduction, and thanks to the panelists for joining me. And I'm going to get us started. I just want to make sure everybody's on the same page regarding the Count Me In Osteosarcoma project, which is about, as you heard, partnering with patients to define the clinical and genomic landscape of this rare aggressive sarcoma in children and adults. And I just want to mention that I'm going to talk only about the osteosarcoma project, but there's a companion project along with this, which is focused on leiomyosarcoma, which is another rare sarcoma and very similar to osteosarcoma in a lot of ways, but mostly affects adults. So these are two companion projects that really work together. But today I'll only talk about osteosarcoma. So just an overview of what I will talk about in the first sort of 25 minutes of this webinar. I'll start with the people who make this work possible, because really it is, it's a project that is about people with sort of patients and patient advocates at the center of it. So presenting on the MIB Osteobites is really kind of the ideal place to talk about this. I'll tell you a little bit about Count Me In, patient-partnered research, a little bit of background for sort of how we ended up with this project in osteosarcoma. The project is actually, excitingly, part of a Cancer Moonshot grant and a network funded by the Cancer Moonshot called the Patient Engagement Cancer Genomic Sequencing Network. So I'll tell you just a little bit about that. And then I'll mostly turn it over to Ben, who will talk about the osteosarcoma project, study procedures, and progress. And then I'll hand it back over to myself to talk a little bit about our early findings. So as I mentioned, I wanted to start with the people who make this possible. And the people who make this possible are the panelists, people like Christina, people like you joining this webinar. This project wouldn't exist without you, to be totally honest. It's about you. It's about your experience with osteosarcoma. It's about you helping us make progress. And I really think it's transformative that we're having these kinds of conversations. And I just want to thank all of you who are here and thank the organizations who have come together around this project. It's also about the people on this slide who, this is a huge team effort. We're bringing together lots of different research approaches, and it requires a huge team to do that. And this is the team shown here with some of the leaders of the team highlighted in bold in this list. And I'm showing you on the right-hand side to Dr. Nick Wagley, who is a medical oncologist, and Dr. Corey Painter, who has a PhD and is also a survivor of angiosarcoma. And the Count Me In, which I'm going to tell you about in the next few slides, is really, they had the idea and sort of launched the platform. And this is the one of the landing pages for Count Me In. And what Count Me In is really about is it's an idea and it's a platform. And the idea is very simple. The idea is that we will learn the most if we are partnering with patients and families in how we do our research, and that we can make that partnership easier, lower the barriers to that partnership by bringing the research directly to patients and their families, and not making them enter a brick and mortar building and sort of work with us on our arcane systems in the hospital, which mostly involve paper. That the time of doing that kind of research is, I don't want to say it's in the past, but there are sort of more modern and advanced ways that we can do this. And so the Count Me In platform is an electronic platform. It's available online, and it's available to really anyone who has cancer now, but in particular for the Osteosarcoma Project, anyone who has osteosarcoma and any family that's affected by osteosarcoma. So that's sort of the platform idea. And at the time that we sort of first started engaging with Count Me In, they already had 6 projects ongoing, and the different colors denote these different projects. And I'm showing you sort of the landing pages for those projects along the top. And then on this map, you can see where participants for each of these projects had lived at the time that they sort of engaged with the project. And so really, we're bringing the project across the entire United States. I'm just going to show you an example from the angiosarcoma project, which had been sort of conducted before we launched the osteosarcoma project. You can see the landing page for the website up here on the left. You can see the map where all of the patients enrolled on the project from. And this is the product of the project. This is a paper in Nature Medicine. For those of you who aren't academic doctors, Nature Medicine is our best journal. It's where we sort of, our most important work gets published there. Publishing manuscripts in medicine is sort of how we doctors and researchers communicate with each other. And basically what the researchers and patient participants were able to do together is to get enough patients with angiosarcoma. Angiosarcoma is extremely rare, actually rarer, I think, than osteosarcoma, to get a bunch of patients to come together to join this project, to agree to share their information, both through surveys and through sharing their medical records, and to agree to share their tissue into the project. The tumors were, and the patient's saliva, which really represents your normal DNA, or the DNA that's giving the instructions for all the cells in your body. They shared that. About 75 tumor and normal samples were sequenced. And by doing so, the group was able to identify that there's a subgroup of angiosarcoma that occurs in the head and neck that has different features from the other angiosarcomas. And the feature that's different is the number of errors or mutations in the DNA. And that's incredibly important. So it turns out that if you have a lot of mutations in the tumor, in this case, a very, very sort of high number of mutations, sorry, that's this figure over here, then it's more likely that your tumor will be sensitive to one of the new medications that's available for cancer, which is called it's an immunotherapy called immune checkpoint inhibitor, or pembrolizumab. And it turned out that because participants were sharing not just their tumors samples, not just permission to acquire their tumor samples to make it more more accurate, but also a sample of their saliva or blood for their normal cells. They were also sharing their information that Dr. Wagley and Dr. Painter were able to observe that 2 of these patients with the head and neck angiosarcoma that had the high amount of tumor mutations had responded to this pembrolizumab therapy. Their doctor had given it to them and they had responded. This was an incredibly important finding, which was confirmed in clinical trials, which then meant that pembrolizumab or similar medications are now a standard treatment for this sarcoma type. So really this really just demonstrates the power of this platform to engage patients and participants to create a large cohort of a rare sarcoma and to allow us to learn something new. And so I was learning about this at the same time that MIB was starting to hold its factor meetings. And as Christina said in the introduction, sort of starting to bring the communities together, the research community, the patient community, the advocacy community, the families who were affected by this disease. And I thought to myself, wow, I bet this would work in osteosarcoma. And so we started, Dr. Painter, Corey, started talking to people about it, and she agreed. And so that resulted in the first Count Me In Osteosarcoma project, which I'm going to call OS1 project. And I'll explain a little bit more about why that is. The picture you see here is this at the middle is sort of what the first osteosarcoma landing page looked like. On the right-hand side is a group of patients, families, and advocates, and some researchers who met at the Broad Institute and helped us understand how to build this project in a way that was sort of helped explain it properly to the community and also made it sort of accessible to the community. And then we sort of spread the word about the OS project, the way that Count Me In had sort of developed to do that, which is through patients and families who are very engaged with the community, through doctors and care teams, through social media groups, printed brochures, advocacy partners, and support groups. The Osteosarcoma 1 project launched at the Factor meeting in 2019, the one right before COVID, and then ran until September 2022 and consented 198 patients. And I'll tell you a little bit more about what's happened with that project as we get there. So Count Me In is fantastic, but it has, like all fantastic things, it has some challenges and some new directions that it wants to go in. So the first challenge is really around sustaining engagement. So I'm showing you what we call accrual curves from the angiosarcoma project. So if you look across the bottom of this graph on the right, you can see the dates. And if you look going up, that's the total number of patients or saliva kits or blood or tumor tissue that was received, okay? And this orange line is the number of patients or families, if it's a child, although angiosarcoma is rare in children, who consented. And this difference between these top 2 lines are people who registered, people who went on to the website. And the difference between these top 2 lines and the consent is totally expected. Some people go to the website, check it out, enter, hey, I'm a loved one, I'm a patient, whatever. And then for whatever reason, it doesn't make sense for them to move forward for the consent. So that makes complete sense. But what we do see is that about 45% of patients and families don't end up sending in the first sort of engagement activity, which is a saliva kit. And then there's a further drop off. So for about 70% of people, we don't actually receive a tumor tissue sample. And there's a lot of good reasons for that, which you'll understand once you hear Ben talk a little bit more about the procedures. But this was one of the things, this sort of sustainment of engagement or attrition as we go forward into the activities that we wanted to address. The second one was that although the data generated from the angiosarcoma project and all the other Count Me In projects are made available broadly to the community very early on in the project, we don't hold on to that data until we find something exciting. We release the data continuously, not continuously, but periodically. We weren't actually sending back any results to the individual participant about their own tumor or their own samples. And we wanted to try to do that. And then, although we do broad outreach, like everything, like you've heard about in a lot of different domains, we probably don't reach all the diversity of the patient population with the disease as we would like. So for example, they have a metastatic prostate cancer patient. And although it has a high proportion of rural participants, there was a low proportion of non-white participants. And Hispanic and Latino individuals represent less than 4% of CalMean enrollees across the program, compared to about 18% of the U.S. population. So we wanted to focus on diversity as well. At the same time, my group at the Dana-Farber had the experience of returning genomic sequencing results to patients in a collaborative project that spanned 13 institutions. And in that project, we actually had a lot of osteosarcoma patients. At this point, we have about 150 osteosarcoma patients participating. We sort of developed an approach to bringing in tumors from across the country, sequencing those, and sending results back out. So we had that experience. And luckily, there was the opportunity to apply for some additional funding for this osteosarcoma project through by becoming part of what's called the Patient Engagement and Cancer Genomic Sequencing Network. And that network was, as I mentioned, funded by the Cancer Moonshot Initiative. And the purpose of it is to promote and support direct engagement of diverse groups of underrepresented cancer patients and survivors to address gaps in the knowledge of genomics in rare cancers. And in fact, these two sarcomas we applied with, osteosarcoma and leiomyosarcoma, are rare cancers and affect people for whom we have gaps in knowledge. And for osteosarcoma in particular, it's a cancer that affects adolescents and young adults. And the truth is that we haven't done as well in sequencing and engaging adolescents and young adults in our research around cancer genomics. So we were very fortunate to get funding. I'll just mention that the initial osteosarcoma project was launched just as a matter of faith. We'll figure out how to pay for this. We actually had no dedicated funding for the initial project, so we're very glad that we have dedicated funding. So we're one of 6 different institutions who are involved in this network. Sorry, just make sure that somehow I can't advance again. Okay, so I think everyone on this call probably knows what osteosarcoma is, but I just wanted to emphasize the reason we were able to sort of be part of this network is because of the impact on adolescents. For leiomyosarcoma, it's the impact on women, because women are also a fairly understudied patient population. The other thing that's interesting or different about osteosarcoma is the genomic nature of it. What does the DNA look like in the osteosarcoma tumor cell? And I'll tell you a little bit about that on one slide coming up. I think, again, probably people on this call don't need to know or be told there's been minimal improvement in survival or treatment-related side effects. And this is in part due to insufficient characterization of what we call the genomic landscape. And I'll explain what I mean by that on the next 2 slides. So we felt there was a need to generate a large shared database of clinical and genomic data in osteosarcoma. And that's really what this osteosarcoma project plans to do. And we think we can overcome this problem because we have this sort of very powerful platform and because we have you to engage with us. So let me tell you a little bit about osteosarcoma sort of genomics and what I mean by that. So in every cell, there's DNA. DNA is the instruction manual for the cell. The DNA in your cells comes from your parents, so it's inherited. It's passed down, and you get 1 copy of each chromosome from each parent. What happens in osteosarcoma, or really any cancer, is that one cell develops some errors or some abnormalities that then give it a growth advantage. It grows too much. In osteosarcoma, the way the DNA errors happen is something called chromothripsis. The DNA kind of falls apart and it gets stitched back together. So in this picture in the red box, what you should see is one of each chromosome that look basically exactly similar to each other. I don't know if you can see, but these are the chromosomes from a tumor cell that are kind of laid out by numbers. We number the chromosomes, and they go 1 through 22, and then we have 2 sex chromosomes, 1 for male and 1 for female. And instead, what you see is this incredible kind of chaos, actually. And this is the sort of modern way of showing that chaos, but it's somehow easier to conceptualize or visualize when you show it this way. And it's not that we don't know what some of the common changes are in what some of the common errors are that lead to osteosarcoma or that we see in osteosarcoma. It's that we haven't really done a good job of making the connection between those errors and the patients. And so let me explain that. So I take care of a lot of osteosarcoma patients, and I've been doing it now for quite a while. And so I'm going to tell you about 2 patients of mine, same chemotherapy, same doctor. I have an 11-year-old girl who had metastases at diagnosis. She progressed on treatment. The treatment didn't work, and she lived for 7 years. And I have a 16-year-old boy who had metastases at diagnosis. The initial MAP treatment didn't work how we hoped. There was some progression, and he only lived 9 months. So there's something different about these 2 patients, right? And it's got to be something more than that he's a boy and she's a girl. And it's got to be something more than their age. There's something underlying the sort of nature or flavor of the tumor that explains this. But we so far have failed to correlate what we understand about the errors in osteosarcoma with the people and their cancer journey or their cancer story and sort of what happens. And so because of that, we don't have what we call biologic subtypes. And all cancers have biologic subtypes. So there isn't a single cancer out there that doesn't have different versions of the same thing. It looks the same under the microscope, but they're actually different. And the reason it's important for us to understand these subtypes is that's needed in order to identify new therapies, which new therapies are most important to pursue and in which patients. We can't understand the studies that are happening in mice because we don't understand how the mice that are getting the new drugs in the laboratory relate to the patients that we see in the clinic, because the mice models are also representative of those subtypes, so we don't know how to map them onto the subtypes in the patients. And we don't know how to counsel patients and families in the clinic because I can tell what I often say is there are different subtypes of osteosarcoma. I just don't know how to identify yours right now. And that bothers me. And so our goal is to engage osteosarcoma patients across the United States and Canada as partners to generate this large publicly available data set that will have clinical, genomic, molecular, and patient-reported data, which will accelerate discoveries and drive new treatment strategies, new clinical trials, and new standards of care. Just to highlight some of the specifics here, one of sort of our first aim is to establish a network of engaged pediatric and adult participants who will help us create this shared database. We're planning to consent 1,000 patients with osteosarcoma over the course of the study. We're going to collect medical records, patient-reported data and surveys, tumor samples, saliva, and blood samples. We will then take those samples and we will sequence them. Which means reading the DNA. We're going to do it in lots of different ways. Can answer that question if people have questions about that, but I'm not going to describe all of them here. And we're also sequencing circulating tumor DNA. We can find the tumor DNA actually in the blood, and we will share that data in a sort of periodic way throughout the study, even before we've had a chance to analyze it, but we will also analyze it. And then we're also trying to do better all the time, engaging patients. So we actually have a component of this study where we're actually studying how well we're engaging patients, how well are we doing, and trying to iterate on that and do better. And we have a particular focus on rural and minority participants and participants of different literacy levels, ages, and stages of development. This is a project that crosses 5 institutions. So I'm sitting today at the Broad Institution. You can see the Dana-Farber logo behind me. Count Me In is the platform, and it's actually its own semi-independent organization. Boston Children's Hospital is where my patients are admitted. So I also am from Boston Children's, and the laboratory that will interpret the sequencing is that for the reporting back to our participants is at Boston Children's, and then Harvard Medical School is our academic home. We have 4 different units running the project. So there's sort of an administrative unit. There's our participant engagement unit, which is really sort of our Count Me In team who are really directly engaged with the patients. We have our sequencing unit, and then we have our unit that's sort of studying engagement and suggesting ways to improve. So here, I think I'm turning it over to you, correct, Ben, to talk about the actual landing page for the osteosarcoma project, or am I to present this one? Yes? Okay, great.
Yes. Sorry, I accidentally double clicked and made my face the whole screen. I'm like, where did the slide go? So found myself. Thank you so much for the overview, Katie, of the OS project. I want to give us a chance to get into the Q&A. So I'm going to run through this relatively quickly, but of course, happy to answer more questions as they come up in the Q&A. So as Katie mentioned, we launched the original osteosarcoma project at Factor in 2019, which was super exciting. And then in September 2022, we had the opportunity to relaunch the project with what we're calling OS2, or the Osteosarcoma Project 2. A lot of the participation looks very similar to the original Osteosarcoma project, but in this version of the project, there's a few additional opportunities for folks to get more involved in the project if they would like. Some differences that I wanted to highlight in the OS2 project is an enhanced outreach team. We're really focusing on expanding our social media outreach now that we're in kind of a better place with the pandemic, attending more conferences, sharing the word about the project, really getting the word out there. One exciting part of this version of the project is shared somatic learning. So what that means is a lot of the times in the past, we've received feedback from participants of, I'm giving you all this information from medical records, surveys, and my samples. How come I'm not getting any individual information back? And so this is one way that we're kind of taking a first pass at sharing information back with participants. So once we receive a tumor sample with a paired normal sample, so a saliva or a blood sample to compare to the tumor sample when we do sequencing, we may be able to return a letter back to participants that kind of describes what we found in their tumor. It's not meant to be clinically actionable, but it's meant to highlight kind of like our appreciation for their participation in research. And since, all of the participants have given us so much data and information, kind of a token of appreciation and sharing back what we've learned on a more individualized level. In addition, for folks who we receive a saliva or blood sample from in addition to a tumor sample, there's an opportunity with our partners at Invitae for additional germline testing. So for folks who are interested in that, you'll be able to provide an additional saliva sample, and Invitae will perform a multi-cancer panel on that extra saliva sample, and that will be looking more at the normal DNA rather than the tumor DNA. And again, that looks at 84 different genes associated with various types of cancer, including sarcoma. In the past, building the OS1 project, we're keeping kind of like we've had a standing patient advisory committee to help us build the project for the original osteosarcoma project. We're keeping that around for this version of the project, especially as we expand into kind of these new areas of sharing information back to participants. Not only do we want to hear your feedback and your help building the project, we want to hear how this is all resonating and how participation looks and how it's feeling as you're going through the process. And we also have a dedicated funded sequencing and analysis team to perform clinical grade sequencing so that we're able in some cases to provide more information about what we've learned from your tumor or your normal samples. One important thing that I wanted to highlight here is that for folks who maybe signed up for the OS1 project and have not reconsented to the new version of the project, we'll still sequence those tumors and we will include them in our analysis and our data releases. And you can go ahead and move to the next slide, Katie. So we have a lot of different outreach materials. Recently got some new one-pagers for the project just to describe what is the project. We're continuing to do online outreach through social media. We will be at Factor in 2 weeks. I'm super excited. I'm bringing my MIB Agents cape that I got at the Outsmarting Osteosarcoma event in February. Can't wait. We are enabling kind of recontacting participants who have participated in tissue banking studies from other studies. And we really also want to focus on physician engagement so that we can get researchers and doctors just as excited about the project as patients are. Quick overview of the study procedures. This is all like very complex, but I'm going to boil it down quickly just to highlight how participation in the project works. So you'll start out by completing a baseline pre-qualifier survey just to make sure you're eligible for the study. We're open to anyone who has ever been diagnosed with osteosarcoma in the US or Canada. Then you'll be taken to our online consent and assent forms. That gives us permission to include you in the study. You can fill out the medical record release, which will allow us to get obtain copies of your medical records. From there, with the medical records, we'll use what we find in the medical record to request any tissue samples that we may be able to sequence along with saliva and blood kits. So after you fill out all of your consent form, and as you're working on the surveys, in parallel, we'll send you a saliva kit and a blood kit if you decide that you'd also like to provide a blood sample with instructions on how to provide those samples. In some cases, again, as I mentioned before, you may be able to receive shared learnings from what we've learned from your tumor sequencing. After we request the medical records and tumor samples, we receive those samples and we sequence them using various types of genomic sequencing. And for folks who are interested in learning more about their normal DNA with Invitae, we're also offering genetic counseling pre-appointment. Then you provide your sample and then a post-appointment so that you kind of know what to expect from this testing, and also kind of have someone to talk through the results as they come in.
Yeah, Ben, we actually had a question just come in about how long it takes approximately. Yeah. So from the time of registering consent to actually having the shared learnings, what can patients and families expect in terms of the timeline?
Yeah, that's a great question. I think in terms of the timeline, it's really dependent on for shared learnings on a tumor sample, it's very dependent on the many different factors of participation leading up to us sequencing the tumor sample. So once you consent and fill out your medical release, our team will go ahead and request medical records from the institutions where you've received treatments. Once we receive those medical records, our team will be able to go through and say, okay, we've found a few samples that we're able to request. We need to request those samples and receive them back into our hands. Then we make sure that we have either a saliva or blood sample to pair that with. And then we send it off for sequencing. Once it goes through sequencing and we have information from the sequencer, we pass that information along to a clinical pathologist who will write the shared learnings letter, and then eventually it will get returned back into participants' dashboards. So it is relatively, there's not a really concrete time frame, but I would say for the somatic return of results or shared learnings, it is on the order of months. Whereas for folks who we receive a tumor sample from and you go through the Invitae pipeline with the additional germline or normal sample sequencing and panel, from the time you provide your sample, you should receive information on your results within 2 to 4 weeks. So the germline sequencing through Invitae is a little bit, in fact, a lot quicker than the shared learnings from the tumor samples that we collect. But of course, we will get those back to you as soon as we're able to. There's just a lot of different factors that contribute to how long that can take.
So I'm going to, if you don't mind, Christina and Ben, I'll just say 2 more things on the somatic shared learnings. And I'm just going to go back one slide. There's some differences between this and standard return of sequencing results ordered by your doctor in the clinic. And those couple of things are in osteosarcoma, sort of immediately actionable variants, meaning mutations that we find in the tumor that have an immediate implication for sort of what kind of treatment you should be getting, are really uncommon. And so for many patients, tumor sequencing is just not a standard part of their care, although many doctors have research programs like mine where we do it, and it is helping us learn a lot, and sometimes can be very informative for you and for your doctor. But it's but that's just where we are right now in osteosarcoma. In our sequencing, unlike the sequencing your doctor orders, our results are going to go directly to you. They're not going to go to a doctor. And like Ben just described, we have a lot less control over the timeline than your doctor does. So if your doctor orders sequencing from, they know exactly what tumor they want to get it from, and they are able to talk directly to the pathologist who did that and sort of place the order for that tumor sample to be sent. Whereas we're reliant on a different hospital's pathology department getting around to sending us the tumor on a timeline that they have to sort of prioritize our research project along with everything else that they do. And so because of that, we sort of reframed return of results to sharing what we're learning about your tumor genome. And that's why Ben sort of introduced this as we're giving you information as a way for you to sort of further engage in the project, but you shouldn't really think of it as the same thing as your doctor doing your clinical testing of your tumor. That said, it is a clinical test. We're doing this in a laboratory that is certified for doing clinical testing. Let me tell you just a little bit more about the test. It's whole exome sequencing, and it's the tumor and the germline, but what you're returning back in the shared somatic learning is just about the tumor DNA. It's not about all your normal cells. And even though we're looking at all the genes that get turned into protein, which is what the whole exome is, we're focused on telling you about 47 genes where we already have information in osteosarcoma. Just to sort of normalize this, a lot of the tumor sequencing panels that are out there are around 500 cancer genes. So it's a smaller set of genes that we're giving you information about. This is the germline results that Ben has alluded to a couple of times with Invitae, and I think he's explained it really well already. Just to tell you that that what you get access to through this program is testing the blood or saliva rather for 84 different genes that can cause cancer. Some of which are really sarcoma specific, but some of which are related to other types of cancer that are not sarcoma. And just one thing to mention is that you will, if you get a positive result back, Invitae or their partner Genome Medical provides the opportunity for you to meet with a genetic counselor to talk about what that means, including thinking about testing other family members. I'm going to skip that slide and I'm going to go back to the update because I want to get back to questions really quickly.
Yeah, I'd love to get to some of the questions.
Yeah, exactly. So Ben, do you want to just highlight right now how many patients are enrolled on the osteosarcoma project really quick?
Yeah, I'll quickly highlight that we have 90 folks who have consented to the OS2 version of the project. This does not include folks who have registered for OS1 before we relaunched. We also have 77 folks who have consented to receiving that shared learnings that we're talking about, and 20 folks so far who have consented to additional germline sequencing through Invitae. We just started sending out saliva kits in February, so you can see that line's a little bit lower than the rest of our lines, but of course, definitely ramping that up and excited to get more saliva kits and blood kits out. Happy to answer any questions, but I also want to get to the Q&A. This is a quick breakdown of sex assigned at birth for folks who are in the project. Relatively even split, maybe a few more females, 53% versus 40. And then you can kind of see the distribution of age at diagnosis for folks who have consented to the project.
And then this is just to show you that we're sort of consenting and reaching patients all across, all across the country, basically. These are 31 patients who've received care at 34 different institutions. And I'm going to skip the feedback and we're just going to move to the questions.
Thank you.
We're
No, that was great.
That's all I'm going to say. And we're excited to hear your feedback today.
Yeah, well, we have so we have the Rambers here who actually are participating in Count Me In, and then we also have Max and Jillian who have not yet. So it's great that we have kind of different perspectives and experiences. And so I wanted to just start with Colette and Allie and just kind of ask you guys what motivated you to sign up for Count Me In, and how has your experience been?
It's super easy to do. We first signed up for the original project back in, it was probably 2020 before we signed up. And at the time, her cancer was really hard to diagnose. We didn't figure it out until after surgery what it was. But I just realized with osteo, like, you hear a lot about funding not being enough, but a lot of it is about not having enough information because it's such a small population of people who have it. And as a parent, the one thing you want more than anything is answers and better treatments. And this seemed like a really easy way to do that. And that it wasn't too hard on her to do these things. So it seemed like a great way to get everybody's information together and to hopefully help everybody, including her, you know.
And Colette, so I think you guys signed up pretty early on to that initial project. And so did you do the reconsent? I know Ben kind of mentioned reconsent. We actually had a question come in too about reconsenting. So did you go through a reconsent process for OS2? And can you just tell us about that?
Yeah, I think at first we got another saliva kit and I was like, what? We already did this. And then I probably missed a communication or something where there was a launch, and we found out there is another launch. So we filled out the paperwork, and the paperwork was really easy to fill out. We had some family history, some personal experiences that maybe could be useful as well. But really it was just kind of redoing the process again. She did another saliva kit, which you can tell them about, like, how that works.
Yeah, it's just super easy, just quick, like, at home, fast.
Yeah. And then with the blood samples, it's really nice as you can just do that at your next appointment or anything like that, you know, so you don't have to worry about getting poked twice. And one thing I loved about it is it was so, like, we'll take any information you want, but you don't have to provide all of it. So when we reconsented, like, Allie does not want to know her germline results. That's something she doesn't want to have to worry about. So we are able to say, like, here, you take all the information, but we don't want to hear any of the results. So there's a lot of flexibility as far as the program, I think.
Well, that's great. I didn't know that. And then Ben, maybe could you clarify as well? So if someone did sign up pre-September 2022, they would have needed to reconsent. But the question someone also just asked is, if they did reconsent, are they then fully participating in OS2?
That's a great question. So if you in order, you'll need to reconsent to the new version of the project in order to be a part of the new version of the project. But as we mentioned previously, any information from OS1 will still be included in our data releases. So we're not excluding any data there. Once you re-sign up for the new project with the new consent form, you'll need to just fill out the medical release again, which tells us where you've received treatment. And if it's been a couple of years since you signed up for the OS project, maybe you've received treatment at a new institution. So it's an opportunity to kind of keep that updated. And then it will take you through our various surveys, which ask more about your experience with cancer, about you, and then your family history of cancer. And then beyond that, once you receive a saliva kit and or blood kit, you're welcome to provide those samples. And beyond that, our team really focuses on taking a lot of the administrative burden from there and reaching out to institutions to get your medical records and any tumor samples.
That's great. And for anyone who can't remember if they did reconsent, how can they check?
Yes, if you go to www.osproject.org/dashboard, if you remember your login credentials, if not, there's a way to reset your password. Once you get in, you'll see a research consent form, and it'll say like when you filled it out. And if there's another version of the research consent form that hasn't been filled out, you'll know that's for the new version of the study, and you'll be able to fill that out. Of course, if there's any confusion or questions, our phone number and email is on the website. You're welcome to reach out to us. We can answer any questions you have. And also, if you need help kind of like understanding what the consent process is like, we're happy to answer any questions.
And I just wanted to mention that we're in the process of drafting an email to all the OS1 participants who haven't consented to OS2 that we're going to send out to sort of do a second round of messaging about, hey, we have a new project and you should sign up for it if you would like to. And we'll highlight kind of what's new in the new project. And then we're also going to, mention that also at MIB Factor, if that's okay with you, Christina, just so people know. And then once we start doing that, we're going to start to request the tumors under OS1. And so we just want people to know that before we go ahead and do that.
Yep. Okay, Max and Jillian, I wanted to ask you guys, since you haven't yet signed up for Count Me In, what question you guys have as you're thinking about whether or not this is something that you want to participate in. And then also, I am not quite sure how old you guys are, and you don't have to share if you don't want, but I also am just wondering kind of at what age the patient can consent themselves, or at what point the caregiver or parent needs to also be involved in the process. But Max and Jillian, if you guys want to jump in with whatever questions you might have about as you think about signing up for Count Me In.
So the first question is, isn't my health information and data already online somewhere? And if it's already collected online, can it be sent in any way?
Yeah, Max, that's a great question. So your health information is definitely already sort of online, but it's online inside this very arcane system called the electronic medical record, which is fairly impenetrable for researchers like us, at least right now. So right now it's kind of unstructured and we're not allowed to access it. Even when you sign those release permissions, it doesn't allow us to like just get right into your electronic medical record. I could understand how you might think that that's the case because of kind of what you hear about how modern our kind of medical records system is. But we haven't quite realized that new world dream where like it's suddenly just available for all of us for research. So we do need people to consent and to give us permission. And also we're actually, one of the things that we're looking at going forward is whether there are certain patients who might want to help us even more by either sending us access to their electronic medical record or working with us to sort of get their own records out of that system and send them to us directly. It's a great question.
And I could also touch, Christina, quickly on your question about turning 18 and depending on when you sign up. So every state, most states in the US have age of majority as age 18. If you're below 18, you'll need your parents' help to sign up for the project. If you're below 7, then your parent will consent for the project on behalf of you. And if you're between 7 and the age of majority, then your parent will fill out the consent form, and then there will be an additional form called the assent form. That's a little more, the language is a little more friendly to younger folks, and you'll need to agree to that as well. As your 18th birthday approaches, or as you reach that age of majority, we'll email the parent and say, hey, this person is about to become a legal adult. Could you please give us their email address so that we can reach out to them and they can reconsent for the study. And then once you're 18, you are fully in charge of your participation in the project. So you'll need to complete those consent forms, and there will be no additional aspects needed from your parent or guardian.
Okay, well, I actually have two questions. One is like not to do with my own participation in the study, but you mentioned earlier, Dr. Janeway, that you you started this OS2 project without like dedicated funding. So how did you manage to get that funding in the end?
How did we manage to fund the beginning? Part of the funding is all from philanthropy, from, people who spend their hard-earned time and money dedicating it to research of cancer, and especially research of pediatric cancer. So it was funded through mostly donation money in the beginning.
That's wonderful. Okay.
It's wonderful
if I
thing
already-
about donation money. It sets you up to get more money.
Yes, that's wonderful. If I already had like genomic sequencing done on my tumor and like heredity testing done, do I still need to participate, or does that already go into some sort of database?
That's a great question. So one of the things that we collect from your medical record is the information about the sequencing you already had. So your permission, giving us permission, you're basically giving us a permission to be the clearinghouse for all that information. So it gets aggregated somewhere, because right now it's at like 17 different hospitals and 10 different companies. You osteosarcoma people out there have had your sequencing done at lots of different places. And so even if one of the things we're doing is aggregating that information, but we're also in this project doing a type of sequencing and characterization of the tumor and the germline that's more extensive than what's done for sort of standard clinical. And so we're hoping to discover new things by doing that. So your participation in contributing samples will hopefully help us go beyond what we already know.
And I'll just quickly add, sort of related, even if there's no samples available for the project, it's still extremely valuable to participate in the project, because we can learn a lot from the information, not only from your medical record, but from the surveys that you fill out when you're participating. Those graphs of sex assigned at birth and age of diagnosis is from the surveys that you fill out. And we ask a question in our About You survey of, tell us anything that you like about your experience with cancer. And I think that's pretty unique to our study, and it really gives participants an opportunity to tell us whatever information that they would like. And that information can be extremely valuable. So even if there's no samples available, or you don't want to provide a saliva or blood sample, it's still extremely helpful and impactful to be a part of the project.
I wanted to there's a question that came in through the Q&A about, and you guys touched on this a little bit, that research priority for the NIMHD is patient engagement in minority populations. What efforts currently exist in this area for the CMI project?
Yeah, so for Calmian, the platform as a whole has a whole community engagement and stakeholder engagement group who specialize in, outreach and engagement. And some of those individuals specialize in outreach and engagement to sort of underrepresented populations, which include racial and ethnic minority populations. In this project in particular, we have dedicated extra funding for patients who are Latino or Hispanic and non-English speaking. So we have a dedicated outreach engagement individual who's focused on that patient population.
Great. And another question came in, and I think you mentioned, so if they sent in a saliva sample for OS1, do they need to send in a second sample for OS2? And it sounds like the answer is yes.
Yep, the answer is yes to that, because in OS2, because we're able to, in some cases, provide additional information back to participants, we're doing sequencing at the clinical grade. So it's a little bit different grade of sequencing than we do for research samples that are not, information is not being returned back to participants. A lot of it has to do with chain of custody and and like labeling information. So it's not to say that the samples that we receive for OS1 are not valuable. It's just a different way to process those samples. So that's why we ask for an additional sample for OS2.
Great. Okay, we're almost out of time, but I want to just sneak in one more question before we close, which is, if you are a bereaved family, is there a way for you to participate, send in medical records and archive samples for your loved one?
So right now, for folks who have lost a loved one to osteosarcoma, we are not, if for someone who has already passed away, we are not able to currently consent them to the study due to, unfortunately, regulatory restrictions. However, if you go onto the website and, at the beginning you're asked a few questions, there's an option that says, I've lost a loved one to osteosarcoma. You can fill out a survey that tells us more information about the loved one that you've lost. It won't be exactly the same as participating in the study, but it will give us more information there. And this is something that we've received a lot of feedback on. So we're definitely working as a team to see in the future, how we can expand our reach to folks who have lost loved ones to OS. And Katie, feel free to add if I missed anything.
No, I would say it's a goal to figure out a way to do that. We think it's really important for the project, and we will try to figure it out.
Great.
And we're gonna need your help doing it. So we will be contacting some people to help us figure out the right way to do this, because we don't want to do it the wrong way. But that's a goal.
Yeah. Well, it takes a village. That's the whole concept behind Count Me In, right?
Yeah,
It takes a
exactly.
village for us all to participate. So thank you so much, Dr. Janeway, Ben, Colette, Allie, Max, and Jillian for joining us on OsteoBites today and making it better for osteosarcoma patients. More information on this and all OsteoBites can be found on our YouTube channel, on our website at mibagents.org, and at your favorite podcast place. And if you're looking for more information on Count Me In, osproject.org, and Ben too, if you want to put that in the chat so people can easily access that URL, that would be great. Next week, on June 15th, we're going to be dropping a new episode of Osteo. Osteo Warriors Camille and Mia are going to be discussing coping with humor, a review of cancer memes. These ladies are hilarious when they're just talking about like the worst topics. So I imagine that topic is going to be super funny. So look for that on June 15th. We're going to be on break for a few weeks from OsteoBites because we're going to be at Factor in Atlanta. And then we're going to be recovering from Factor in Atlanta and also the July 4th holiday. But we are going to be back on July 13th. We're going to be talking with Dr. Jeffrey Bryan. He is the director of the Tom and Betty Scott Endowed Program in Veterinary Oncology at the University of Missouri. And he's also the associate director of comparative oncology for the Ellis Fishel Cancer Center. And he's going to be joining us to discuss click chemistry, a pre-targeted approach for delivery of radiopharmaceutical therapy for bone cancer. You can find our OsteoBites lineup for the next few months on our website. And if you have any ideas for future topics that you'd like to hear about, just drop us a line at events@mibagents.org. Thank you so much to our wonderful guests today and for all of you for spending an hour with us. We hope to see you back here on July 13th for OsteoBites when we talk to Dr. Jeffrey Bryan. Thanks so much. Hope to see you at Factor, and remember to place a bid for outbidding. All right. Thanks, everyone.
Looking forward to Factor. Bye, everyone.
Thanks. Bye.
Bye.